Welcome to back. Today we are lucky to have Amy Nan, who's going to talk about novel markers of stress in early life, sex ratios, preterm births, and milk miRNAs. I want to announce our next two talks. So we have Greg Grether coming on February 23rd from EEB, and he'll be talking about behavioral interference between species. And then on March 9th, we have Olympia Campbell coming from the Institute for Advanced Study in Toulouse. And she will talk about cousin marriage, women's welfare, and accelerated family formation. And I want to thank our funders. It's mainly funded by the UCLA Dean of Social Sciences, but also the Departments of Anthropology and Communication, and occasionally private donors. Thank you, Amy. I'm going to turn it over to you now.
Okay, thank you. Can everybody hear me okay? Yes?
Yes.
Yes. Okay, thank you, Casey. Hi. Thanks so much for having me. Thanks for the introduction. Excited to be here today to talk to you all about preterm births and sex ratios. You might notice that I changed the title of my talk slightly since I sent in the abstract. I decided I was overly ambitious to try to talk about three different topics and shove them all into 1 hour. So I actually don't think we're going to have time to talk about milk microRNAs today. And I apologize if anyone's here just because they're really excited about milk and microRNAs. But if you are, I'm happy to talk about it in the Q&A or to meet with people at another time to talk about milk microRNAs. But I'm going to focus today on preterm births and sex ratios because I think they tell a really interesting story about stress at a population level and that they're, yeah, really interesting and cool ways of trying to capture what's going on within a particular group at a population level. So I will start there. Oh, I guess I should also introduce that I'm from UCSD. I think that was mentioned in bioanthropology. And maybe I should say also I run an epigenetics lab. So you might have also hoped that I'd be talking about DNA methylation today, which is a lot of what I do. But I'm excited about these newer projects that take me in a different direction. So also happy to talk about DNA methylation later if you have questions. Okay. So, a lot of my work is united by this question about different mechanisms and biological paths that lead to developmental origins of health and disease. So, this is just this theory that I'm sure most of you are familiar with, that there can be very sensitive or critical windows during early development that where they're very influenced by the environment and they can shape patterns of growth, development, and health throughout the whole life course. So today I'm going to talk about preterm births and sex ratios, which are around the perinatal period, around influences near conception and in utero that might actually be shaping health and development and gender of the offspring. Um, but if I had time, I'd talk about milk also in the postnatal period, but we'll get to that another time. So today I'll talk about preterm births and sex ratios. So I'm sure you're all heard of preterm birth as a global problem. Preterm birth is typically defined as any birth that occurs less than 37 weeks of gestation. There are different types of preterm births. You can have early preterm births, which are like before 34 weeks, or very early, which are even sooner, or late preterm births. But in general, I'm going to talk about this definition of preterm birth today, which is just the general one of less than 37 weeks. And I want to give a little bit of background because preterm births can be either spontaneous, they just happen where nobody really knows why, or they can be induced medically for a particular reason. So we think spontaneous births might be a combination of things like psychosocial stress. We see more stressed moms having more preterm births. Things like infections can lead to more preterm births, comorbidities, other diseases. Problems with the placenta, twins and multiple gestations like triplets or more lead to preterm birth more often. But induced preterm births are those where the doctor has picked up on an issue, like there's a concern about the placenta or the mother has hypertension and the doctor might induce a preterm birth for the sake of the health of the mother or the baby. So I said they're a leading global problem. It's actually the leading cause of death in children under 5 globally. In the US, we have pretty good control over the situation when preterm births happen. Actually, um, less than 10% of preterm babies in the US die, whereas it's the opposite in many other countries, less high income countries. Preterm birth is a leading cause of death. And the rate in the US is interesting. We actually have 10% of US babies born preterm, which is pretty high. And if you compare the rate in the US to other high income countries, it's actually much higher than other similar countries like in Europe, where the rate on average in European countries is around 6%. Um, our rate of preterm birth is closer to the countries in Africa, which is average around like 11 to 12%. And we don't really know why, but we know we invest a lot of money, right, in the US in reproductive care and in our medical system, and yet we have really bad outcomes. And this is one of those where we just have a really high preterm birth rate. One reason might be that we have really big racial differences in preterm births, and that could be a result of many factors. Including medical care differences, access to care, stress level, comorbidities, all different things might be driving these racial differences. But we have much higher rates of preterm births among Black mothers and Indigenous mothers, like close to 15% and 12% relative to white mothers and babies were closer to 9% in the latest data that I was searching for. And that's been pretty consistent over time that Black babies tend to be born preterm way more than other babies. Oh, just to show you this, we gathered all the data from the CDC, and I just wanted to show you quickly, there's huge racial disparities in preterm births in the US. And you can see the top line is red is the Black mothers are having preterm births at much higher rates consistently. And this is showing since 2015 over the last 6 years, but much longer in time, much higher rates than any other group, followed by Native Hawaiian or Pacific Islanders and American Indians, and then Hispanics in the middle, and white and Asian babies are much fewer preterm births at the bottom. And that's been very consistent for decades and has this gap in race hasn't shrunk over time. I also wanted to show you nativity has an unexpected and interesting effect on preterm birth, where mothers who are born outside of the US actually tend to have better birth outcomes, which maybe you're not surprised by. But for many people, it's surprising that moving to the US, the more time you spend in the US, right, the worse your health tends to be. And mothers that are born outside of the US relative to inside have lower rates of preterm births, which is the blue line down here, and higher rates if they're born in the US. And that holds across most racial and ethnic groups, but not all of them. Like Pacific Islanders, it's the reverse. But for most groups, if you're born in the US, you have higher rates of preterm birth than otherwise. Okay, so that was just background to orient you to the preterm birth situation in the US. But what I'm really interested in for preterm birth is its relation to stress at the population level, because I think it's a very interesting metric of um, exposure to highly stressful social, political situations. So just two examples here that I want to show is that people have looked at the preterm birth rate among specific racial ethnic groups following specific targeted racist instances. So this one is when Trump initiated the Muslim travel ban against women, I'm sorry, against all people from a set of Muslim majority countries in 2017. Women that had Muslim last names ended up having much higher rates of preterm birth, and that was theorized to be more racism and discrimination and stress related to racism affecting their preterm births following the Muslim ban or the stress of the Muslim ban. And also, Latina women following Trump's first election also had higher rates of preterm birth observed relative to expected following Trump's just first election to presidency. So there are examples of preterm birth being a pretty sensitive marker to population stress. And this was in New York City and also nationally in the whole US, they saw the same pattern. So I got into this question about whether preterm birth might have been affected by the stress of the sorry, there's a typo, the COVID-19 pandemic. Um, so I just thought maybe because it was sensitive to stress in other studies, maybe we would see an increase in preterm births during COVID. And I also wondered if we'd see differences by race or ethnicity or other social factors. But surprisingly, when I started reading about preterm births and COVID, we actually saw an unexpected reduction in preterm births at the beginning of COVID. And that was primarily seen in high income countries like Denmark and Ireland and Iceland and Israel, some studies in the US and Italy and Japan, but not in lower income countries like Nepal or Thailand, where they actually saw a rise in preterm births. But it's very curious. Why would preterm births like temporarily significantly decrease in these higher income countries? So one theory when I first started looking into this was what I thought was would explain it was this lockdown effect that being at home, not working at the very beginning of the pandemic, not having to be on your feet during the end of your pregnancy might actually be beneficial, particularly for better off, wealthier women from high income countries or even in the US. I thought maybe the more advantaged women who got to stay home from work or work from home might actually see a benefit for their pregnancy outcomes. So that could be one thing. There are a lot of other theories too, though, like so many things changed at the beginning of COVID. Things like air pollution went down because people were driving less. There were fewer infections, there were fewer car accidents. So it could also be related to those things. But we saw this in so many countries. It made me want to see what we could learn from the pandemic as sort of a natural experiment to see if there was something that shifted that we could take advantage of and try to reduce preterm births moving forward. So, um, at the time I started this study a couple of years ago, most of the research in the US was really inconsistent. People had looked across different regions, delivery types like cesarean versus vaginal, and found different results or timing of preterm birth early versus late. The first meta-analysis I found didn't see any change in preterm births across 16 different US hospitals. Um, One study that used the nationwide CDC data found primarily preterm births reduced only in the non-spontaneous births, which are the medically induced births. So it means they're inducing preterm less often. But the spontaneous ones, which might be more due to stress or other things, did not decrease. Some studies found it was the later preterm births that reduced, but not the earlier preterm births, like the more severe preterm. But nobody looked at sociodemographic factors. Like they didn't break it down by race or ethnicity or education status. So I wanted to see if we saw like the more advantaged women having a benefit during COVID and the least advantaged women maybe not. So that's what I tried to do. And actually, all of this data is publicly available if anyone's interested to look at it. You can download from the National Center for Vital Statistics, or not, yeah, I think National Center for Vital Statistics. There's data on every birth outcome in the nation every year. And the biggest challenge is actually handling that data on a regular laptop because there's 25 million births in just the last 6 years that we looked at. So it's a lot of data points. And it requires some coding expertise and a big computer to handle it. But all that said, our research question was how and for whom did preterm birth rates shift following the early COVID pandemic in the US? And my hypothesis was that I've already hinted at that we would see underserved populations um, seeing actually maybe an increase in preterm births, like Hispanic and non-Hispanic Black women, or non-Native women, or less educated women, or unmarried or uninsured women, maybe increasing, but decreasing preterm births, maybe only among the more advantaged women. And so that's what I thought we would see. Teaser, we didn't see that really very well or hardly at all, but I'll show you step by step. So what we did was we downloaded 6 years of the National Center for Health Statistics, that's the name, of data, which was over 25 million births. And just plotting it by year, you can already see there's this interesting seasonal fluctuation in preterm births, which is also, well, to me was kind of interesting and surprising that Women have more preterm births at certain times of the year than others. It's actually higher in the winter and lower in the summer, I think it was. And each of these represents a different month. So that's January, February, March, April. Yeah, September is the low point. I'll show you in a moment. So there's a seasonal fluctuation. It's also interesting to see that the preterm birth rate has been steadily increasing over time since we looked at it, since the beginning of our plot. So um, that meant we couldn't just compare March or April of 2020 to the average of the year before because it's been increasing over time. And we also couldn't just compare to like the month or two before because there's a seasonal pattern to it. So what we ended up doing was averaging um, the preterm birth rate between April to June, which represents that lockdown period, the quarantine right after, since COVID was announced in the middle to end of March, March 20th, we decided to start in April and look for 3 months and average the preterm birth rate. And then we decided to forecast using both linear models and some time series models, what was the predicted preterm birth rate, and then look at what was the observed and see what the difference was, accounting for that seasonality and the increasing rate over time. So the models just averaged the preterm birth rate in those few months and compared that to the same period every year. And then we use this forecasting model called the autoregressive integrated moving average, or a REMA model, to control for the seasonality and other shifts over time. And I'll show you in a minute what that looks like. So first observation here, I already mentioned, was that the rates have been rising over time, and then they got disrupted in 2020, which is shown in purple. So you can see it's not rising the way it was all these other years. It kind of slows or steadies or holds steady or goes a little bit lower. And then we also noticed the seasonal pattern got disrupted in 2020, which was interesting. So we overlaid all of the years on top of each other. I know it's a little hard to see, but the purple is 2020, and you can see the pattern of the season is wildly different than all of the other years that tend to, they tend to have a low point in September. It still has a low point in September, but the March, April is much lower than you see in other years. And it comes back up again, but it's certainly disrupted in 2020. And in the pink line on here, 2021, it's also disrupted. So since COVID began, the seasonal pattern changed. You can also see it here, the seasonal pattern changed. Can you guys see my mouse? I think you can. Hopefully. Yes. Okay, thanks. So that's interesting. And then we plotted a linear model, really basic one, just accounting for preterm birth rates over time by year, and you can see the blue line is the expected trend over time, accounting for the data from the last 5 years. And then we plotted on top of this where the actual data fall, and I just put red lines to show the residuals or the distance from the expected value. So you can see in 2020 there was a significant decline in the preterm birth rate, and this is the total preterm birth rate in the nation, averaging April to June at the beginning of the pandemic. There was a significant decline. Um, and that was relative to that rising pattern in other years. And it was outside the confidence interval, which is the gray bars here showing that it was outside of even a range of error around what might be expected in that year. So we do see a nationwide drop in preterm births. Relative to prior years. And when we accounted for seasonality in that, using all of the months of data, not just April to June, you can also see the red line represents the actual burst. The blue is what's predicted in this autoregressive moving average model. And you see it's outside of this blue confidence interval. So the rates in March and April really dropped below what was expected and stayed kind of below that expected range for most of 2020 and 2021, and only start to come back up around the end of 2021. So we also see this with this time series analysis. Okay, so my question I posed was there a racial ethnic nativity difference in preterm births during COVID? And we do see something that was kind of unexpected. It kind of drops, the preterm birth rate dropped for most racial ethnic categories, but only significantly for three of them. So the top row is women that were born in the US, And we see white women born in the US and Hispanic women born in the US had a significant decline in their preterm births. Black women also declined, but not quite enough to be significant. It pretty much declined in most of the women except Native Hawaiians or Pacific Islanders here. But when you look outside the US, not all of these groups declined, and only the Hispanics showed a significant decline and actually a bigger decline than any of the other groups. The non-US born Hispanics also have a steeper increase over time, which I thought was kind of intriguing, that things have been getting worse at a steady rate. These axes are not all standardized because we wanted to show you, zoom in on what was going on in COVID. But just a reminder, the rates of all of the preterm births of those born outside the US are pretty much lower than those born inside the US. But focusing in on what happened during COVID, you see only the Hispanic group outside the US dropped in 2020, which is interesting. And we really still don't know why these are the groups that had the biggest drop. So I was theorizing it would be Black and Hispanic women, that it might be non-US born women that were more vulnerable or less able to access care during the pandemic, and maybe they would even see a rise in preterm births, but we saw a drop in just white women and Hispanic women, and only mostly in non-US born Hispanics. I'll come back to that because I did have a theory. Well, I guess I'll mention it now. I had a theory that Hispanic women lost the most jobs at the beginning of COVID. They were the highest rate of unemployment of all racial ethnic groups. So that's one theory I had, is that Hispanic women just were working a lot of labor intensive jobs, and not having to do that right at the ends of their pregnancies could have been beneficial for the preterm birth rate of those women. But I will say, talking to a lot of obstetricians, they argue that being off your feet and not exercising as much is not good for you, and that the literature says that being active and exercising and working is not necessarily harmful for preterm births. So I don't really know if that theory is why, but I'll come back to some other theories I had later. Okay, so looking at education, it was confusing. We broke it down by every possible group. Simplify it, I'm going to just show you those that had more than or equal to a high school degree was the group that significantly dropped in preterm birth rate. That fit my theory that it was the more advantaged women that benefited somehow from working at home and not having the stress of like being out of work, um, or something like that that might have been worse for women that lost their jobs. And those that with less than a high school degree still dropped, but not as much as those with a high school degree or more. We also looked at insurance status and WIC status. If you're not familiar, WIC is the program to help provide nutrition and benefits to women and children of low income. And surprisingly, it was the women with public insurance and self-pay. Those are the, as a proxy for lower income women, actually had a bigger drop, a more significant decline in their preterm birth rate than the privately insured women, though they also dropped. Looking at this, kind of the takeaway to me is they all dropped, but the only ones that dropped outside the confidence interval were those that were receiving WIC or not, regardless of WIC status, but those that had public insurance or self-pay. So there's not like a consistent pattern, if you're getting that, of higher SES women benefiting from the pandemic necessarily. So then we decided to dive deeper and look at maybe aspects of delivery or care that could explain differences in preterm births during COVID. So we separated the births by delivery type. The top row are the induced births. So they're induced cesarean on the left and induced vaginal births on the right. And you see a significant decline, really dramatic in the induced vaginal births, but also in the cesareans, but not in the non-induced. So these are what I call the spontaneous. Spontaneous births did not decline, just like that other study I mentioned earlier showed. They pretty much stayed the same. So it's really the medically induced births that are dropping the most in the US during COVID, which is so interesting and shows me that maybe it's not about stress at all. It's about obstetric practice and policies at the beginning of COVID, and they were inducing preterm less often. So then we Well, I'll get back to this later, but we actually ended up doing an entire qualitative study after noticing this, where we interviewed 15 obstetricians and midwives, and we asked them questions about their policies and hospital practices and guidelines during COVID that might have changed and could help explain why there were fewer induced preterm births at the beginning of COVID. And I'll come back to that in a few minutes. Okay. But to finish this, we also looked at prenatal visits and to see maybe women were accessing prenatal care less frequently because of the quarantine or not having access to telehealth. So this is just the data on how many prenatal visits women had over time. And it's been very consistently around 11.3 prenatal visits over the past 5, 6 years, but in 2020, it dramatically dropped. This plot is very zoomed in, so it looks more dramatic than it actually was. It went from like 11.3 to around 10.8. It's less than one visit less. It's like half a visit less on average, but you're talking over like 4 million births in a year. We're seeing an average of less than one or like half of a visit less. So it's a significant decline in people coming in to see their doctors for prenatal care. And we grouped them into three groups after that just to see, is it the women that are coming in less that are seeing a decline or the women coming in more? And it turned out the women with the least prenatal care had the biggest decline. Those that already didn't see their doctors very often had less preterm births the most during COVID. Those that had a moderate amount of prenatal care, like the average, like 11 to 15, I think 15 is the national average, they also declined. And it was only women that had 16 or more prenatal visits that didn't change. And that makes sense to me because women that are seeing their doctor so often actually are usually high risk. And high risk clinicians we talked to, maternal fetal medicine specialists, told us they did not stop seeing their patients as frequently as they did before. They kept maintaining that visit schedule because those patients needed to see them because they were high risk. So this is kind of indicating it was maybe the lower risk patients in the middle that declined, and also those that were already not seeing their clinicians that declined. Okay. So then some clinicians asked me this question, could it be that we're just seeing more fetal deaths? And that's why we're seeing less preterm births because they're not making it to be born at the beginning of COVID. And I just want to remind you, this is the first couple of months of lockdown. It's before most women had COVID at all. It was just the start of the outbreak of the pandemic. So we don't think the women in the study, many of them had COVID, that we don't have that data. Um, but we thought, well, maybe the stress of the pandemic could have led to more miscarriages and fewer preterm births as a result. So we also looked at fetal deaths, which is also publicly available from the CDC. And we found a dramatic decline, significant, in fetal deaths in those same months where we see the decline in preterm births. So it's not because there's more fetal deaths that we're seeing less preterm births. We're also actually seeing fewer fetal deaths in this same period. So that can't be the primary explanation. Then we wanted to know, well, maybe there's fewer preterm births, but maybe it's not a good thing. Maybe there's like more babies being carried later to term, later in pregnancy, but they're not having good outcomes, like they should have been born preterm and they didn't get to be. Um, and so we looked at maternal ICU and neonatal ICU admissions, and we saw significant, well, not quite significant, sorry, small declines in the maternal ICU and the NICU admissions. This one's almost significant. And so that also indicates that it wasn't necessarily more harmful on average overall that we saw fewer preterm births. Maybe there was actually a benefit. And the reason we were thinking it could be harmful is like in part, one of the theories I'll get to is that the clinicians thought we're missing critical indicators for preterm birth when women are coming in to get care less often. They're not picking up on hypertension or risks of preeclampsia as often, or gestational diabetes, or whatever it might be. And so they're not inducing as early as they used to. And maybe that would be a bad thing Um, for and so the fewer preterm births could be just a result of having less attentive care, but actually it didn't lead to more NICUs. We don't have a lot of data on the babies because this is just from uh, generic nationwide data that's available online, but we didn't see anything worse happening. Okay. So, to sum up all of this about preterm birth, we saw a significant drop in preterm birth for most women in the US, actually, during the beginning of COVID. And then the rates rose again in 2021. I didn't really focus on that, but it was a temporary decline. It came back up again, and it's just as bad as it was before. But during the beginning of COVID, it definitely declined, and it declined the most for Hispanic women, for women with a high school degree or greater, also white women, I forgot to mention there. And like I mentioned already, Hispanic women did lose the most jobs during COVID. So that is one possible explanation. Also, women with higher degrees were maybe able to benefit more from staying at home, spending time with their families, not panicking about their income yet. And then we saw induced preterm births drop the most of all categories of women. It was the women that were induced that had the fewest preterm, like induced preterm births decreased the most, regardless of whether they were vaginal or cesarean. So that finding paired with the finding of not the fetal deaths rising makes us think there was something in access to care, or obstetric interventions rather than stress that's really driving this big drop in preterm births. And I already mentioned, so it may be um, that we were missing the indicators for preterm inductions. We were missing out on detecting high blood pressure, which is one of the biggest drivers of a preterm induction. And so women weren't coming in, they weren't getting their blood pressure measured, and we were missing it and catching them too late after they weren't preterm anymore, but they were in danger. Or this other theory came out of our interviews with clinicians that maybe we've been over medicalizing pregnancy forever in this country, and COVID was actually an opportunity to intervene less. And maybe there was a benefit for a lot of women, and that we were causing like iatrogenic inductions before, meaning, like medically induced that weren't necessary or helpful. And COVID was an opportunity to reduce that medicalization and induce preterm less often. And maybe that was a good thing. So we interviewed a whole bunch of obstetricians and midwives, like I mentioned. Um, and those were the two theories that emerged from those interviews. And we just checked if they emerged unprompted versus prompted, which is the red and the blue. But if you combine those together, it's like the majority of clinicians all agreed that both of the missing indicators and the over medicalization were probably relevant to the decrease in preterm birth during COVID. But it was surprising to me, like half of the clinicians mentioned over medicalization as a problem in our medical system, which makes us think we need more discussion of how much prenatal care we require of women, particularly the lower risk women, and maybe we're inducing preterm too often. So we called it the double-edged sword of reduced prenatal care. There may be some women that were harmed by it, but maybe some women were benefiting from it, and maybe those were the lower risk pregnancies that benefited. I also thought it was interesting just last year, the American College of Obstetricians and Gynecologists changed their guidelines, reducing the recommended number of prenatal visits from 12 to 14 down to 6 to 10, which aligned with what the clinicians were telling us in our interviews that maybe we did have too much interventions, too much prenatal care, that led to too many iatrogenic preterm births, and they weren't actually necessary before COVID. And that's a interesting lesson that we might need to take forward out of the pandemic, that maybe we didn't need as much prenatal care. But I caution not for everyone, only probably for the lower risk pregnancies, because the higher risk ones still needed that care and benefited from that care. Okay, so that was a quick whirlwind into everything we've looked at with preterm birth, but I want to shift gears and talk about sex ratios. But maybe this is a good time to pause and just take questions on this study before we move on to the next one. Does that work, Casey, or should I wait till the end?
take some now.
Susan said
We
it's
could
fine
take
to
some
take
now.
some now. Yeah.
Okay.
If anyone in the Zoom wants to unmute themselves, feel free to ask a question. Otherwise, we can save it till the end. Matt again.
Yeah, let me know if you can't hear my question, but
Yeah.
so as I'm sure you're aware, but maternal like fetal outcomes in the US are particularly bad when compared to like other
Mm.
weird countries. Do you think this is
Yeah.
a the new direction of the like reducing potentially increase reducing the number of inductions is a move in the right direction, I guess?
Yeah, so thank you for that question. I do think reducing in inductions preterm is a move in the right direction, but I want to state it's confusing, and I didn't show you this plot because it's confusing, but inductions themselves actually increased during COVID, at the beginning of COVID. And I talked to a lot of obstetricians about that observation too, why that would be, because we saw inductions going up, but preterm inductions went down. And some of them theorized that women wanted more control over the timing of their birth when they were panicking about everything during COVID. Maybe also the obstetricians wanted more control over the timing of the births when we were worried so much about infection at the very beginning of the pandemic. So they actually were inducing more, even though they were inducing preterm less. And I do I do think that rise in inductions is problematic and partly a result of policy. I didn't mention this either, but there was a big clinical trial called the Arrive trial in 2018. I think it was 2018 that came out and found that reproductive outcomes improve when you induce a little bit earlier than previously recommended, so around like 39 weeks of pregnancy. Um, they said that you're less likely to have a birth ending in a C-section. So they had a reduction in cesareans if they induced at 39 weeks rather than waiting till the full 40 weeks. And so clinical practice nationwide has actually been to induce more and more. Since that Arrive trial came out, inductions have gone up and up and up. Partly probably because of those guidelines, but also just because we keep over medicalizing. That's the direction of our medical system. So it's a hard question to say if inductions are always bad. They do reduce cesareans, as that study showed, but I do think we get carried away. And when we start inducing before preterm, before a baby is term, it's dangerous. And so clinicians mentioned to me like maybe a woman that runs up the stairs to go see her doctor or has a little bit of anxiety seeing her doctor, has high blood pressure one or two times, and then they would recommend inducing her early because they're worried about hypertension in pregnancy or preeclampsia. And so that kind of induction seems to be the unnecessary kind. And I think, yeah, I think we could back off a bit on inducing the lower risk pregnancies for sure. If that's a long-winded answer to your question. Other questions?
I had a couple of quick
Yes.
questions. One real quickly, how did the total number of births change? And second, it seems, unless I'm missing something, it seems like the analysis is assuming that the effects or prenatal births are determined by conditions right around the time of birth. But as a non-expert, I would think that they would be determined by events prior, like closer to conception, for example. Or did you account for that?
So we don't have lots of data about the changing health over the pregnancy. We only have data from what the CDC posts online. So we only had whether or not they had um, hypertension, if they had preeclampsia or not. So I can't say if earlier rather than later events in the pregnancy affected the preterm births, but the fact that we saw a drop in preterm births primarily among the induced births and not the spontaneous ones makes me think it is at the time of conception that was, I'm sorry, the time of birth that was driving that, because that was, sorry, I'm trying to get back to that plot here. So these non-spontaneous preterm births are the ones that dropped dramatically, and it was the spontaneous ones that didn't. And yeah, earlier things in the pregnancy could influence these, but I think it's only the decision of the clinician to induce that is influencing this, and that's at the time of the birth. I don't know if that's really answering your question.
Yeah, that helps. Thank you.
Yeah. Okay. Anne, I see on Zoom has a hand.
Hi, this
Hi.
is so interesting. Thank you. I've been curious about the miscarriages dropping and
Yeah.
like how you theorize that that might relate or not to the over medicalization.
Yeah. So they dropped. Yeah. I also thought that would be related to the over medicalization. I don't know. It's complicated. There's a lot of confounders because a lot of things changed at the beginning of COVID, like things like air pollution and traffic accidents, as well as access to care. But yeah, less miscarriages. I don't know if I thought about it that way, but I think you're right. I think it could be, but I don't know what medical care would induce a miscarriage necessarily. Um, I think part of it could be just that they are, it's not that they're not getting recorded as much because every death and every birth gets recorded, even if they happen at home. But I was just thinking that like maybe we're not tracking as well during COVID, or um, I don't know. I really don't know. I don't know what over medicalization could do that could lead to more fetal deaths. I call it fetal deaths rather than miscarriages, by the way, just because the very narrow definition of the fetal deaths on the CDC is deaths that occur at 20 weeks or more of gestation. So this is late term
Okay.
or later term fetal deaths, not early term miscarriages. So we don't have any data on early term miscarriages, but these are like midway to later. Um, and those declined. I mean, maybe it also is less stress from staying at home. I know a lot of people said that goes both ways, like staying at home with your family who demands a lot of you. And if you're teaching, like you're taking over their education, and if you live in a multi-generational busy house, it might be difficult to be at home. But for others, we thought it would be beneficial to be around your family, have that social support. Everything you think that could cause stress could also be a benefit or a harm from staying at home. So we didn't have an easy answer about whether just staying at home was helpful or not. But I still think that for the better educated women who had higher paying jobs working from home, they were probably less stressed than the women um, than they were maybe having to commute all the time to work and or being on their feet. Yeah.
Amy. So
Hi.
without at all contesting the over medicalization, which I think is clearly evident, in
Mhm.
lots of prior work as well. I do want to draw attention to, if I understood correctly, one feature of your data, which is that the Latina women born outside of the United States had fewer
Yeah.
preterm births, and that I think potentially is more consistent with what you were just saying just now. Because if you think that first generation immigrants are more likely to have an intact extended family structure as part of the home environment in which there is more support, right? Then
Yep.
lockdown period can be a period of, enhanced care for the pregnant woman rather than reduced
Yeah.
from the family members, especially if some of those family members would normally have been working outside the home in wage labor, and now they're available to share in a variety of the household responsibilities and childcare responsibilities and so on, right? So I think without discounting over medicalization, at least for subpopulations here, it may be the case that there were net benefits for the pregnant woman, not necessarily for the family as a whole of the lockdown.
Yes, I totally agree. And I had that same thought that those multi-generational households provide more social support for the mom and just like, yeah, cooking for her, supporting her during the end of her pregnancy could be really beneficial to those women in Hispanic groups, particularly those from outside the US. Yeah. And I do think there were benefits and harms happening at the same time in different subgroups, but even within the same subgroups. So that's why we called it that double-edged sword, because I think both are not mutually exclusive explanations. I think um, there were women that were harmed by this less access to care, but also women who benefited by that reduced over medicalization and other things like being able to be home with their families. Yeah, for sure.
Yeah,
Thank
and
you.
just pursuing that in a different direction as well. I wonder whether the data are sufficient to allow you to parse a little bit further beyond simply having a high school degree or not. And
Yes.
here I'm thinking of, more educated, white collar women are less likely to have those intergenerational households. They're less likely to have extended care within the home, and they're more likely to be suffering the stressors of childcare responsibilities, given that that's a social class where they previously would have outsourced a lot of the childcare responsibilities to educators and professional care providers.
So you're saying the lower income white women might have the
No.
worst outcome,
White collar,
or no?
not white ethnicity.
White
So
collared. Okay,
yes.
yes, white
So
collared.
you
Yes.
know, I'm thinking here, college educated professional women who they're more likely to live far from non-nuclear family members, right? From extended family members.
Yes. Mhm.
They're less likely to live in an intergenerational household, and they're more likely to have previously been, reliant on the education system and professional child care providers to care for children that now, all of a sudden they're thrown into a situation where they're largely responsible for their education, the education of their children and distance learning and the care of their preschool age children. And that could be extremely stressful. So I wonder if you can parse simply having a high school degree or not, I think is too crude a differentiation because women who have a high school degree, say in especially rural parts of the country, they are probably, still, within geographic, proximity to extended family members, whereas women with a college degree, I think, are probably much less likely to have the advantages of
Yeah,
intergenerational care.
that's a great idea. I just brought up this slide. I don't know if you can see it because I hid it from the presentation because it was complicated, but
Okay.
this it is complicated that not every higher educated group had a reduction in preterm birth. It was mainly the doctorate or professional degrees, a small reduction in master's and bachelor's, but not outside the confidence interval, and a reduction in associate's degrees, those with some college credit. The only ones that were significant are the ones I've circled here, but the women with an eighth grade education or less actually have one of the lower preterm birth rates. And this was a weird finding we were surprised by, and they dropped a lot during COVID. And I actually think this is due to the proportion of foreign born versus US born women, because a lot of women with less than an eighth grade degree were foreign born, and they tend to have lower preterm birth rates overall. So I think that's why the overall preterm birth rate is lower in that group. And we did see that this was made up primarily more foreign born women than native born women, US born women. But I don't know why they dropped more during COVID, honestly. So it's not like a consistent pattern across all the educational groups, but maybe if what you're saying is we combine the education and race data together, we could see more subgroup differences of types of women that might benefit or not from being home with their families.
Yeah,
Did I
I mean,
confuse? Yeah.
the data continue to be intriguing, I guess, is what I have to say about that slide.
Yeah.
Right?
Yeah. So I collapsed it into high school or less because it was simpler to explain, but it is interesting to me that we see like is randomly all over the place, but it's the group with 9th through 12th grade that don't have a degree. And they had like almost no change. And I think that's what's driving the less than high school group to have less of a change. Whereas the high school or more averaging across all these groups, we see the change. But
Yeah.
yes, it's complicated. And every time we break it down, we want to break it down into more and more and more groups, and we end up making thousands of plots, and we've never published it because we keep looking at more and more things. So I am very grateful to your feedback and ideas so we can build them into our final version. And if you have other ideas, please send them to me because we have still not finalized this. Still working to try to figure out what's driving it. Really, it's complicated. Yeah.
Really interesting.
Thank you. Should I move on to the next section? You
Yeah,
think?
and then we can come
Yeah,
back for questions after.
we can come back to have more questions that you might be thinking of. Yeah. All right. So moving on to sex ratios. So uh this grew out of random curiosity also at the beginning of COVID when I had learned about sex ratio differences being kind of reflecting population level stressors when I was a postdoctoral fellow, and I had toured around different universities, and I met Ray Catalano, and he told me all about the Trivers-Willard hypothesis. And I always thought it was so interesting to think that something that's happening at the population level could influence the sex ratio of the offspring. And so I just want to give you a little bit of background of the studies that have found that, and then how we looked at it during COVID in a very similar way to the preterm birth ratio. So sex ratios at birth is just the total number of males divided by the total number of births. So when I talk about sex ratio at birth or the SRB, it's really, if it's higher, it means more boys. If it's lower than 50%, it means fewer boys or more girls. And so globally, we actually favor male births over female births in the whole world. We see an average sex ratio around 0.51. It's very slightly favoring male births over female births. And this theory that it could fluctuate with stress or with like some toxic endogenous exposure is driven by this Trivers-Willard hypothesis, dates back to the 70s. I'm sure a lot of you have heard of it since you have an evolutionary theory background, but it's this idea that mammalian mothers living in poor conditions are more likely to have female rather than male offspring to maximize their chance of reproductive success. So it's saying during times of stress or adverse conditions like a famine or a war or something, um, that mammalian mothers favor having female babies over males, and not at the individual level, but at the population level. And the idea is that daughters are a safer bet under adverse conditions. They're more likely to survive to birth. They're more likely to survive infancy and childhood and survive to reproduce. And um, and on the opposite side, sons are favored under good conditions. And that may be because when conditions are good, they're not held back by the constraints of childbearing or lactation that slows down their ability to have babies. They can have many more children under good conditions than females can. But under poor conditions, it may be that daughters are a safer bet. And this is backed by a lot of data across a lot of different animals. I keep seeing red-tailed deer or red deer, sorry. Red deer is a foundational study that shows, that they're as a proxy for good social conditions, they actually ranked the deer as low versus high social rank. So the more dominant females tended to have more male offspring, and the less dominant females had fewer male offspring. And so this is showing that under good conditions, females are favoring giving birth to males and the opposite. So the mechanisms behind this are confusing and many-fold, and we still don't really know what's driving this. And if this applies to humans, really, is still a controversial question. Um, it could be that boys are less likely to be conceived in the first place. So at the moment of conception, it could be that under stressful conditions, girls are just conceived more successfully. It could also be sometime during the whole gestation, um, boys are selectively miscarried more often because they're less likely to survive. So there's like a selective self-abortion of boys over girls. Um, just to show you, this sex ratio does seem to be influenced by social and economic factors and demographic factors. So there are racial differences in the sex ratio in the US, where Black African American babies have a lower sex ratio, meaning fewer, yeah, fewer boys, more girls. And American Indians are next, followed by white, and actually Asian or Pacific Islanders have higher sex ratios, according to this study from 2023. There's also studies that show differences in entire countries' sex ratios if they have a higher GDP, or studies that show billionaires relative to non-billionaires have the billionaires having higher sex ratios, meaning more sons. So those that are better off economically by GDP of the country, or particular billionaires relative to not, tend to have a higher sex ratio at birth. Um, which is interesting, I think, that there's something about the social conditions influencing the ratio of the sex of the babies. Um, what's more interesting to me is that like something like a population level stressor, like a terrorist attack, like 9/11, I'm sorry, 9/11, yeah, 2001, they saw the lowest sex ratio across the entire study period, 4 months after the 9/11 attack in New York City. And so there was a reduction in the sex ratio following 9/11. There's also been studies of other terrorist attacks or political violence, everything from JFK's assassination, the Sandy Hook shootings in Connecticut, the Rodney King riots, the North Ireland troubles, the Breivik shooting in Norway. They've all seen a reduction in the sex ratio around 4 to 5 months after the event. So you'll see there's a pattern. Sometimes it's happening 4 to 5 months. Some studies are showing it happening 9 months. So I'll get to those. Sorry, some of my animations are off, but my question was, did it decrease at the beginning of the pandemic due to pandemic stress, just like with preterm births? And so a couple of studies had looked in South Africa, and one study had looked in England and Wales, and they found it did decrease 3 to 5 months after the onset of the pandemic in those countries. Another study looked in the US, but only among twins. And another one looked in Norway, only among twins, and they saw fewer boys born in twin pairs than expected in the US. And that was around the second or third trimester of exposure to COVID. So those that were pregnant in the second or third trimester at the start of COVID ended up having fewer boys when twins were born. And then there were some studies I mentioned that found a reduction in the sex ratio 9 months after COVID, and that was in Japan. There was a decrease in the sex ratio, 9 months indicating something around the time of conception that influenced the conception of boys versus girls. But it also rose in England and Wales 9 months after. So it decreased 3 to 5 months in England and Wales, but rose in England and Wales 9 months later. So there's a lot going on. This is an image from the study of the US twins, and you can see these three cohorts, conception cohorts that were conceived around, I think it was January of 2020, then gave birth to fewer twin boys, twins, lower sex ratio among twins is what I meant to say. Okay. So I published a study with a student of mine, actually an undergraduate, who was really impressive and figured out how to do these time moving average models all on her own. I give her all the credit for this study coming to fruition. And I just tasked her with answering this question: do you think fewer boys were born in the US during the beginning of COVID? And we hypothesized we might see it either 3 to 5 months after COVID or 9 months after COVID based on those other studies. And we also thought we would see it among non-white mothers more than maybe the white mothers or those with low SES from whatever metrics we had of SES relative to those of higher SES because of the higher stress during the pandemic on those vulnerable groups. So we looked across 6 years, 2015, yeah, 6 years of data, 25 million births. And we saw the sex ratio trends here overlaid for every year. And you can see 2020 is in purple. It was no different than any of the other years. At just a first glance, you can see the monthly sex ratio trends were the same. The seasonal pattern was the same. And then we did this autoregressive moving average model, this time series analysis to account for seasonal variation and changes over time, like increasing over time or anything that might have been driving it. And we did not see a significant change in the sex ratio at birth in the total US data. So it didn't fit with the South African study or the England and Wales study that saw this change or the Japanese study. So we dug a little deeper. We decided to break it down by race, break it down by every factor we had, which was basically race and ethnicity, maternal age, and education level. And we looked both at those raw effects of those things as well as interactions between those groups and the time period. So we saw first we modeled 3 to 5 months after COVID. If they were exposed to COVID, 3 to 5 months prior to birth, the odds of the male birth were actually basically one. There was no greater odds of having a male birth than a female birth. The confidence interval crossed 1. So there was just no way to say that there was a change at 3 to 5 months or at 9 months. Neither one found a change in the sex ratio, but we did see significant differences relative to white for Black babies, Asian babies, and Hispanic babies. The Black babies were less likely to have a male birth. The Asians were more likely. The Hispanics were slightly less likely. Women with less than a 12-year education were slightly less likely to have a male birth. With each increasing year of maternal age, there was a slight reduction in the odds of a male birth. So remember, these are teeny, teeny, tiny changes, but at a population level of millions of births, this does make a difference. And then in model 2, we looked at 9 months and saw the same pattern. No effect of 9 months, but effects of race and education and age. So I thought, okay, there wasn't a COVID effect in the US like in other countries. That's maybe easy to understand because we also saw there wasn't like a rise in preterm births in COVID. There was actually a decrease in preterm births, as we just talked about. So maybe the stress of the pandemic just didn't have as big an effect on reproductive outcomes in the US as it did in other countries. The US is big and diverse and complicated. We differ sociodemographically than those other places. We also differed in like how people perceived the pandemic at the beginning of COVID. If you remember, a lot of politicians were downplaying the outbreak and denying it and pretending that it wasn't as bad as it was and telling people to go out or not wear masks or whatever. So maybe there were just differences in the response to the pandemic and there wasn't as much panic. Hard to say. But I think the more interesting finding than not having a reduction in the sex ratio is that we did see a reduction in the sex ratio by different demographic groups, not during COVID, but just in general. Black mothers had fewer boys, and those with less education had fewer boys. And the older the mom was, the less odds of her having a boy. So that just reinforces to me that the sex ratio might be a useful indicator of whether the entire population of, say, Black mothers or less educated mothers are under more stress, and that's why they're having fewer boys than girls. I still can't say we have a mechanism for how this is happening, but I've read some speculative theories that stress can affect hormones. Chronic hypertension can affect hormones in pregnancy, and it may be those hormones that are affecting the sex at conception. So that would explain the 9-month effect in those countries that saw a 9-month effect. And in the countries that saw it as a 3 to 5 month after COVID effect. It may be the stress is just influencing hormones again, stress on its own, cortisol may alter the survival of the male fetus and lead to more miscarriages. So I ended up collaborating with a colleague in Ireland who actually wrote that first paper about the decline in the sex ratio in South Africa. Um, his name was Gwinyai Masukame. It's a funny story, actually. I reached out to him because we noticed a mistake in his table in one of his papers. And we just actually, my undergrad noticed the mistake. She was brilliant. And she noticed this mistake and she pointed it out to me. I reached out to him. I asked him about it. We never resolved the mistake in his table, but he ended up eagerly wanting to collaborate. He had all this data on Ireland and he had analyzed it already and saw that there was a massive, or not massive, a dramatic decline relative to the entire study period, the lowest sex ratio ever observed in 9 months after the beginning of COVID in Ireland. So in Ireland, we did see the decrease in the sex ratio 9 months after COVID. Um, and this was the opposite pattern of what he had found in England and Wales, where it actually increased at 9 months, even though it declined at 4 to 5 months, it increased at 9 months in England and Wales. And so we were theorizing maybe the pandemic stress at conception was favoring females in this population, but maybe it was something else. And so Gwinyai had this theory that it was, oh, I messed up the animation again, sorry. But it may be related to the frequency of sexual activity and not having to do with stress at all. But he had read these studies that showed that when there's a lot of sexual activity during any period of time, like after a war, when men come back from war, there's studies that show there is a change in the timing of conception. So, sorry, one sec. I think I just swallowed a flea. One sec. When there's more frequent sexual activity, then you're more likely to conceive at a population level earlier in the fertile window. So I just drew a picture here. Earlier in this fertile window, the hormones are different than in the midpoint of the fertile window. And there's higher ratio of estrogen in this earlier part of the fertile window relative to gonadotrophins. And they think that maybe that higher ratio is leading to more boy conceptions. But when there's less sexual activity, more of the pregnancies get conceived in the middle of the fertile window. And I think it's just a statistical thing. Like you're more likely to conceive outside the most fertile period if they're just having more sex. And so if they're conceiving outside the most fertile period, the hormones are different, and that might lead to more boys being conceived than girls. So really not having to do with stress at all. Um, and so this guy named James in 2000 did all these studies. It gives me a little bit of pause that no one else has really found this or supported this. So I don't know how much stock to put into this theory about the hormones being different and driving the sex ratios. But this guy found that conceptions on the most fertile days led to a lower sex ratio than conceptions on other days in the cycle. And he claims to have seen it. Actually, he did a meta-analysis where he brought together data from other animal models and white-tailed deer, Barbary macaques, golden hamsters, Norway rats, mice, and pigs also show this similar phenomena where conceptions on the more fertile days lead to lower sex ratios. So maybe there is some validity to this. I haven't seen it in humans really studied since this one particular study. But I think it's interesting. So in Ireland, what might be happening is there was less sexual activity at the beginning of COVID. And one of the reasons he thought this might be is because Ireland's health service executive actually made a public service announcement that everybody should stop having sex. They said they should limit their partner intercourse. And their response to the pandemic was just like very moderated and controlled. And he just thought people were listening to this advice. They were having less sex. And there was even a corroboratory decline in STDs at the same time, in the same month where we saw less sex when these births were conceived 9 months prior. So in December, after 9 months after the declaration of the pandemic in Ireland, it seems there was a decline in births as well as a decline in male births. So maybe people were having less sex and having fewer babies. Oh, yeah, one of you asked me that question if fewer babies were born in the US at that time, but I actually don't know. I don't remember if fewer babies were born in the US, but in Ireland, I know there were fewer babies 9 months after conception, 9 months after COVID. Okay, so then this led to one other study we did with North Ireland compared to the Republic of Ireland, just because we had that data too. So we thought, why not look? And surprisingly, the pattern was different in North Ireland compared to the Republic of Ireland. We actually saw a rise in the sex ratio 9 months after COVID, right? And here we saw a decline 9 months after COVID. So it was the actual opposite. Um, and we also saw, is this the daily live births, a decline in births at that time. So, but there was a rise 5 months after, sorry, a decline in the sex ratio 5 months after COVID, but a rise 9 months later. So the pattern aligned more with what was going on in England and Wales than it aligned with what was going on in the rest of Ireland, the Republic of Ireland, which, if you're familiar with the sociopolitical history, the the ties of North Ireland, which is part of the UK, may have outweighed the geographic ties to the Republic of Ireland, and they were probably following the same policies and telling people to have less or more sex in the same way in the UK as they did in Northern Ireland, but in the Republic of Ireland, it was independent. So it did seem like North Ireland matched, yeah, more with England and Wales pattern than it did with the rest of Ireland. So that was all I had. It's confusing, but it's interesting that I think it's a combination, right? A combination of stress and timing of conception, which is related to sexual activity. And curious to hear your thoughts or questions about that too. And I just want to thank all the undergrads, the brilliant undergrads that help with these both preterm birth and sex ratio studies and the fellowships that funded their research at UCSD too. Thanks.
So thanks, Amy. It's really interesting. Kind of a couple of points. First, on your US results, where you were looking at the effects of SES,
Yes.
Black ethnic identity, and maternal age. I think it's useful to kind of separate out functionalist and proximate possible explanations there. So my understanding of the Trivers-Willard hypothesis is that low-ranking females benefit by having daughters because daughters are always in demand, and since they're a limiting factor in male reproductive success. But high-ranking females benefit by having sons because they have privileged access to reproductive opportunities, right? So in highly structured systems like the red deer, for example, it works out pretty well.
Mm-hmm.
I think that can apply to historically disadvantaged groups in the United States, both in terms of economic status and ethnicity, right? But that might be separate than maternal age, where in that case, it may just be if there's reproductive senescence going on, then you get more pregnancy failures in general. And if male conceptions are more fragile, then they're lost at a higher rate. So it may be a constraint rather than an adaptation in that case. And just focusing on this, the sort of adaptationist logic of the Trivers-Willard hypothesis, I don't know if those students are still interested in the question, if they're still working with you, or if there are other students. But there's a lot of discussion right now about the K-shaped economy, right, where the affluent are doing well and the working class are doing more poorly. And it strikes me that that is exactly the circumstance in which the adaptationist logic of the Trivers-Willard hypothesis should apply, where you should see an increase in male births among high SES individuals and an increase in female births or decrease in male births among low SES individuals, and that should, be directly tied to the ratio between income and expenditure, which, as I understand it, although wages have risen, the cost of living has risen proportionately much higher for a lower income than for higher income individuals.
Mhm. Yeah, so you're suggesting we just look at low income versus high income individuals and see if there's
Yeah, now, right. So, right, I'm suggesting that
increasing change in the sex ratio as the economy has gotten more and more stratified, kind of.
exactly, right. So
Yeah,
not looking at the pandemic data, but looking,
yeah,
within like the last 3 years or so, right? Where as inflation has really taken off, this divergence in the earning to expenditure ratio has become more dramatic between low income and high income families.
yeah, that's a great idea. The data is out for 2024 already on the CDC, but not 2025 because there's a big lag in them publishing that data. But we could look 22, 3, and 4 if you think that's recent enough.
Yeah, I would want to look
Yeah.
at and I'm not an economist, right? I'd want to know what the annual change in the
Yeah,
ratios between earning and expenditure of high and low income households is, right? And have
yeah,
that be the correlate to the sex ratios, right? So that you
yeah,
potentially
that's
see
interesting.
you see a change in the ratios over time as there's this divergence in the welfare of the different categories of households.
Yeah, it'd be nice to see when that divergence took off. I mean, I think it's always been bad, but yeah, I agree. It's probably gotten much worse. Yeah.
At least that's what the talking heads tell us, right? I mean, I haven't got
Yeah.
to look, but yeah.
Yeah. Great idea. Thank you. Yeah. The undergrads that helped me the most with this have moved on to grad school. But I bet she'd still be interested in looking at this data. I could reach out to them and see. Yeah.
Yeah, it's very presumptuous of those undergraduates to graduate.
Yeah.
The
And move on
temerity of it.
to actually, they're at Harvard now, so I'm sure they've got lots of free time to look at this data.
There you go.
Yeah.
Hey, it's Abby. How are you? Nice to see you. Thanks for
Hey,
being.
Abby. Hi. Nice to see you.
I want to go back to the first part of your talk, and I was thinking about
Yeah.
ways you could be able to get at medicalization's impact. And I'm
Oh,
wondering
yeah.
if the data exists. I feel like this is a long shot, but I was thinking about ways in which medicalization is different in different hospitals or different practices. And I don't know if you have data, but maybe one way to think about seeing if you could parse it out is if you had OB-GYN deliveries versus nurse midwife deliveries and seeing if there's a if they are distinguished in the drop in preterm births, because you would expect that OB-GYN or MFM would potentially have a steeper decline than it would in a place where you
Yeah.
would expect less medicalization, like nurse midwives. And of course, not
I
all
can share.
states, yeah, not all states
Yes.
have nurse midwives
Mhm.
like in hospitals.
In
There's
the hospitals.
state laws
Yeah.
around that differ. So I know
That's
that's
a great idea. I don't remember if midwife versus doctor is recorded in the CDC data set. I don't remember seeing it,
yeah.
but there is something similar, which is home births versus hospital births. Home births are more less likely to be attended by a clinician, right? And we did see a significant decline in preterm home births, but that's not about less inductions because inductions never happened at the home. Unless you count some kind of chemical or like medicinal induction. But we think that's less spontaneous preterm births at home than before COVID. Um, and there was an increase in home births, a significant increase in home births, and a decrease in hospital births during COVID. which we also thought was interesting, that more women were opting to give birth at home, partly because of the fear of infection at the hospital, but also wanting more control over their pregnancy outcomes, maybe. But it doesn't really address your question because it was at home. Yeah, you're not seeing over medicalization usually happening in home births anyway.
Right,
But
right.
more women opting for home births made us think that was like a shift in preference towards less over medicalization.
Yeah,
Yeah.
definitely. Yes, it's a somewhat of a proxy. I felt like
Yeah.
the idea about nurse midwives versus hospital births might not be available in those data, but
Yeah, I'll double check. I don't remember
cool if it
seeing it.
was.
Yeah. Yeah, it would be cool if it was. There was an interesting question about like uh was it why they chose home, whether it was like they
Mm,
chose to give birth at home versus just gave birth at home by accident. I forgot the term. Um, that we could break down. But there, I don't remember there being a midwife question, but you're right, that would help us get rid of the get at the over medicalization theory.
cool stuff. Thank you.
Thanks. Good idea. Maybe there's another website that has home birth statistics we could find, or I'm sorry, midwife statistics, like midwife outcomes over the period. I'm not sure if anyone records that.
And maybe looking at like prenatal care too, if it's given by, because sometimes with nurse midwives, if they're delivering but didn't give the prenatal care too.
Yeah. And I would suspect there's a difference between midwives delivering in the hospital versus delivering at home as well. Because you still got that hospital interventionist mentality in the hospital, and the midwives step out and the doctors step in when there's an emergency.
Mm-hmm.
Um, Yeah. And I don't want people to come away thinking I think we should stop inducing entirely or that our medical care isn't benefiting women. I think on the whole, it's saving tons of lives, just that we might have taken it a little too far, and there might be some benefit to stepping back in the inductions. Yeah.
I was curious about the like seasonal patterns of
Yeah.
inductions or of preterm birth.
Yeah.
Are there any like theories as to why that happens? I'm
Yes.
guessing, yeah.
One theory was yeah, I had a note on that. I was curious too. Weather, like, but it
Mm-hmm.
didn't fit my expectations. So I've read some studies that say higher temperatures can lead to more preterm births. And so with climate change raising temperatures, we might be seeing more preterm births. But this is showing higher rates in the winter, um, and the lowest rates in September. September is the hottest month here in California, at least in San Diego, but I don't know if that's nationwide.
Mm-hmm.
But something to do with the weather could be explain it because winter could be stressful in parts of the country that get very cold winters on the baby, like physiologically stressful. I don't know. Um, my only theory is weather, but I do think it's interesting that there is this seasonal pattern and it's really consistent, right? It's always the lowest in September and always the highest in the winter, like January, December,
Mm-hmm.
except in COVID. Well, it's still highest in the winter and lowest in September, but the pattern around the middle is all thrown off here at the very beginning of COVID and the next year. Yeah. Um, Maybe more car accidents during winter ice.
Mm-hmm.
Yeah. Yeah. I think I also saw a seasonal pattern with the sex ratio as well. I didn't look at it closely, but as I was talking, I thought I noticed that. Here, this is the sex ratio trends over the year. It definitely peaks in May and is lower in December every single year. November, December is the low point, and the peak is May, June, July,
Mm-hmm.
maybe May, June. Um, Except 2017, there's outlier peak here, but yeah, I don't know. It seems like there's a seasonal pattern to everything.
Yeah.
And I think it's really interesting to wonder like what could be driving these seasonal trends. I don't know. There was even a seasonal pattern to oh, sorry, I was going to say the prenatal visits. I think I had that too. Yeah, check this out. The prenatal visits have a seasonal pattern.
Mm.
Women have more prenatal visits at this part of the year. This is January, February, March, April, May, than they do in the winter. Probably weather. Yeah.
Susan?
Yeah, I was just curious. I think there's some birth seasonality in humans too, right? I mean, it's very subdued, but does that relate in any obvious way to these other seasonal patterns you're saying? I mean, I know these are proportions,
Yeah.
so it's not that,
Yeah, I don't know. I don't
but
know if
that might give you
fewer
some clue as
births.
to what kind of ecological stressors to look for.
Yeah, I guess I've read theories that, yeah. Well, what would the seasonal pattern be? That there's fewer births in the winter? Actually, don't know.
Yeah, I can't remember for
Yeah.
humans. Do you know?
But maybe it's also weather related. Um, it would be interesting to compare different parts of the country, like only because I'm in San Diego and we don't have much winter, and you guys either, right? And so we think of winters as not a big deal, but I wonder if Northeast versus Southwest, there would be a difference in the seasonal pattern that could give us a clue as to if weather was driving it. Unfortunately, to get access to the state and county level data, you have to get permission from the CDC, which I did, and I got access to their private data sets that had the county level information, but they gave it to us in an unusable format that was like unreadable. And every time I asked, they said there's some software or some way to unpack it, and no one ever got it back to me. And this was like 6 years ago. So we did our best with the publicly available data. But if I could get that county level data, we could look. We were thinking of looking with like temperatures in different parts of the country to see if there were temperature patterns, but we never got the county level data. Yeah. But it is cool how many questions you can ask with this kind of nationwide data. And it's out there for anyone if you're interested in downloading it and just exploring. It's also a great exercise in like making plots and learning how to deal with big data. I find for my students, it's been a great learning opportunity. Yeah. Any other questions?
Yeah, so on the frequency of coitus and the sex ratio, I have no
Yeah.
idea whether he ever published this, but I know that in about 1990, a guy named Reed Wadley set off to study this in Kalimantan in Indonesia in Dayak communities. Unfortunately, he's passed away now. So if he didn't publish it, the chances that the data still exist are not that great. Although just coincidentally, his widow is a faculty member here at UCLA. So in principle, we could, pursue if that's an avenue that you're interested in. Like I said, I don't know whether he actually collected the data, and if he did, whether he published it. I know that's what the project was.
So it was about sex ratios in
As a function of,
Indonesia.
yeah, sex ratios in Dayak communities as a function of frequency of coitus. The
Oh,
Dayak
cool.
live in longhouses. They basically have what you might think of as norms of visual and auditory privacy because they're communal longhouses, and so Reed was able to tell when people were having sex, basically. And
This sounds like ethically questionable. Well, I don't know. If there are ethical concerns about sharing that data, yeah.
like I say, I just
Yeah.
know that he set off to do the work. I don't know whether the work was actually performed, and if it was, what the results were, or whether they were ever published. Yeah.
Yeah, I'll look for it and I'll reach out if I decide it's worth pursuing. Thank you.
Yeah.
Yes. It's funny, I was mentioning this study to my violin teacher yesterday in my lesson, and she was like, "This is so interesting, but I don't understand how you would ever get funding to do research on sex ratios or in the US." And I'm like, "I didn't I didn't get funding. I just use the publicly available data because I have the freedom to do that." But but after talking to one of your students, Gabby, we were discussing how the rates of, I mean, your UCLA students this afternoon, the rates of sex ratios in certain primates in zoos are sometimes really biased, and they have too many boys. And it might be that they're having too good of nutrition with increased levels of care in captivity, and that it might actually help conservation efforts to learn if certain feeding conditions or conditions of captivity are shifting the sex ratios in different ways, in which case I could see a grant being interested in funding this research. There is some practical application to the question. I was more just curious, out of curiosity, if sex ratios were influenced by COVID, but I do think there could be some practical applications like that. So thank you, Gabby.
We have time for one more question. Is there someone in the Zoom audience who'd like to ask a question? Okay, I guess that's it. Well, thank you so much for joining us. And
Thank you. It was great to
email her.
bounce ideas off you guys. I love the enthusiasm your group has. Yeah. I think I have some more student meetings, right?
Yes.
Yes.
I
Um,
I think they pick back
Didn't
up at 2:30.